Okay, it is right at 12:30, so I'm gonna go ahead and start. But I'm Katie Shelor. I'm the pediatric nurse practitioner in Peds Neurology, and I am doing a presentation today on staring episodes just because I think it's pretty interesting, and the more I dug into it, I think the muddier it gets. This was kind of to help guide, to maybe see if some of the staring episodes could be pulled out better in primary care. But I think the more that I dug, the harder that became, and you'll kind of see why. So today we're just going to summarize what staring is, and then we're going to evaluate. Talk about evaluation of staring episodes. Then we're going to talk about non-epileptic causes of staring, and then epileptic disorders that can cause staring, and then the different testing that you can do to differentiate between a non-epileptic event and an epileptic event. And then we'll talk about the different treatment options and follow up, or if you need to follow up with neurology or not. All right, so I looked at a lot of different definitions, and I like this one the best from the Cambridge Dictionary, but it's looking at something for a long time with the eyes wide open, especially when surprised, frightened, or thinking. And I think this will be important, especially the thinking part of it, when we get later into the presentation. But I think, if you're a concerned parent and you're doing a quick search for medical reasons for staring, a lot of times it's going to lead you back that this might be epilepsy. And that's one of the main things that I saw when I was searching. So like the first thing that comes up is like, this could be an absence seizure. So I think that really freaks parents out. And we kind of have to find ways that we can reassure them, especially if they're waiting on an appointment with us. So let's talk about ways to evaluate staring episodes. I think the best way to evaluate staring episodes is to get a good history, like anything else, right? But there are very kind of specific things that kind of help me pull out whether the staring episode might be epileptic or non-epileptic. There are certain things where I'm like, ding, ding, that definitely sounds epileptic in my mind, and I'm worried about that a little bit more than something else. So you want to know the age of the child, right? The younger the child is, I think, typically the less likely a staring episode is going to be epileptic, and that increases with age, and you'll see the statistics soon. But how long has this been occurring? Is this something that has been going on forever? Your child just does this all the time? What was happening when the episode occurred? Were we looking at flashing lights? Does it happen every time we run? Is there something that seems to cause these episodes to happen, or does it happen always when we're watching TV? Like both of those are different, and what they can mean as far as it being epileptic or non-epileptic can make the outcome totally different. So how long do the episodes last? Some episodes parents will tell me about that these kids are staring for like 10 minutes at a time. And I'm like, man, that's a really long time. Is it really 10 minutes? When you're thinking about 30 seconds, it doesn't seem like a long time unless you're sitting in silence with someone for 30 seconds, and it's the longest 30 seconds of your life, right? So kind of really need to get a good gauge on how long they're lasting. How frequent are these episodes? So some epileptic syndromes, the episodes will be really, really frequent, and then others not so much for staring. If they're happening like once a month, like, is that probably an epilepsy? It's hard to say, but I think less likely, right? Is there anything that seems to make them occur? So kind of like what I talked about earlier. Do they respond to your voice? So if they're staring and you say, hey, and they respond to you immediately, that's typically a good sign, right? But some kids, and I have a kid just like this, when they're really tuned in to what they're listening to. My daughter really loves Bluey, so if Bluey's on, like, she can't hear me at all. Like, I can say her name a million times, she's not going to respond. She's going to continue staring straight at the TV. So sometimes verbal stimuli is not the best choice when we're trying to understand if the staring episode can be broken by something. Do they respond to tactile stimulation? So when you touch them, do they come out of it, or do they continue kind of staring straight ahead and they're not responding to that? And typically not like a little touch, like are you tickling them or giving them a rub on the chest? Like, are they responding to that? And it doesn't have to be like a sternal rub, just something annoying that most kids would respond to. And does the parent have videos of these? So sometimes this is super helpful when we're looking at staring episodes on what the child's doing during the episode, if there's anything else like subtle that we can notice. This is just a little, if you like charts like if A, then B, then B, then C, this is a great little chart I thought that I found while I was doing my research. But like, does it respond to touch? Yes, seizure is unlikely. So there you go when I'm talking about the tactile stimulation. Like those are probably more related to other things. If they're not responding, like this makes it more likely to be seizure. And then it kind of goes down through like if this and that. And we'll kind of get to that in just a second. So these are some really cool statistics I found in a study. So they studied staring episodes among different age groups. And you can see as we kind of go up in age, the likelihood of it being epilepsy is much higher. So 0 to 2.9 years of age, 9% of those patients, and this was a 10-year study, were diagnosed with an epileptic condition, and 90.3. So the vast majority of them were diagnosed with either normal behavior or a non-epileptic paroxysmal event. And then you get 3 to 12.9-year-olds, 11.9. So a little bit more were diagnosed with an epileptic condition, and then 88.1% were diagnosed with, again, the normal behavior or non-epileptic event. And then the 13 to almost 18-year-olds, this one's even higher. So I feel like this one makes a pretty good jump. But it goes up to 17.5% were diagnosed with an epileptic condition, and then 82.5% were diagnosed with something else like normal behavior or non-epileptic event. So I think those are pretty good statistics. So when we see patients for staring, which we see often, I feel like this is probably pretty correct on how that kind of falls, give or take. So let's talk about non-epileptic causes of staring. So there's lots of them. I'm going to kind of hit the high notes here. But normal behavior. So in the really little kids, so 0 to 3-year-olds, you're going to see that this non-epileptic cause is going to be the biggest one. So statistically, I think it's like 60 to 80% of those children, we just said it was normal behavior. This is part of their development. They're just kind of figuring things out, which might cause staring events when they're trying to figure things out in their head. Inattention and daydreaming, I kind of lump together. They're a little bit different. So inattention is typically related to some comorbidity like a learning disability or ADD or ADHD. And then daydreaming, you or I, all of us could do even if we didn't have a comorbid condition. But we're just thinking about things, and so we stare off into space when we're kind of processing those things. This one was interesting to me, but parasomnias and sleep apnea can aid into non-epileptic causes of staring. There are some migraines that can cause that. Psychogenic non-epileptic spells, which is a very interesting one, which we'll touch on in a second. And then self-gratification can sometimes cause episodes of staring. So I'm going to dive in a little bit more into some of these, but let's talk about inattention and daydreaming. A lot of times with inattention, they're going to have like associated behaviors, not always, but sometimes leg movements. So like the nervous leg movements when you're moving it up and down quickly. Sometimes they'll rock. Sometimes they'll have some hand movements where it just kind of looks like they're fidgeting. That doesn't totally exclude an epileptic disorder, but some of these things that look like more nervous habits, I think, make that a little bit less likely, but still hard to pull out, right? And then I touched on this just a second ago, but comorbidities like ADD or ADHD can increase the likelihood of having just overall inattention, right? So they're known for their inattentiveness. That's kind of part of the disorder. So you can see that. And then having an intellectual disability or autism may increase the likelihood of inattention too. I was looking up just because it's kind of a well-known, I want to say fact, but sometimes the studies are conflicting as far as autism and then epileptic disorders. But there is a studies that show that the incidence of autism and epilepsy kind of go hand in hand, but it seems like the more of an intellectual disability that we have or higher motor deficits increase the risk for epilepsies. So the less of an intellectual disability, the less likely it is to be an epilepsy. So they found that less intellectual disability was only about 7%. So that's like little to no intellectual disability. And then severe intellectual disability and then motor deficits, it was almost 42% in one of the studies that I was looking at. That these kids have epilepsy as well. So you think, right, they probably have something underlying going on. So this could be a genetic factor. There could be something going on with their brain that causes them to have that increased risk for epilepsy. So another thing as far as inattention versus something like an absence seizure, typically with inattention or ADD, ADHD, teachers will often report that they don't remain on task or they don't complete homework if it's inattention related, and less so if it's staring episodes related to an epileptic condition. So staring episodes, they're going to report that like they just weren't responding to me. So it's typically reported a little bit differently. And I found that in studies, that's kind of how teachers report. And I feel like teachers, since they deal with kids, many kids all day long, a lot of times if they're reporting this, there's probably pretty good reason to draw concern to that might be an epileptic condition. And then going back to the study on the previous slide, in children that are 3 and above, somewhere between 40 and 60% of staring episodes were associated with inattention or daydreaming. So that's a pretty good chunk of them that were this and not an epileptic condition. All right, this is not my realm, so I typically do not talk about sleep disorders, but some staring can be associated with sleep-related issues. So a lot of times it's like from sleep arousal, so waking up in the middle of the night. So there are things called confusional arousals where kids will wake up 2 to 3 hours after sleep onset. And a lot of times these children are really distressed and they seem emotional and you can't calm them down. Sometimes they could be staring straight ahead. So most of the time you're going to have both. It's not just going to be a straightforward staring event. So it's kind of hard to call that just a staring event. Probably need to look into that a little bit further. There's sleep terrors, right? So we're thinking kind of more along nightmares, that sort of thing. Sleepwalking, I think, can be a little bit more confusing because when you think of sleepwalking, we think of the children that get up in the middle of the night and kind of wander around. But it could be as simple as they're waking up, they look awake, but they're kind of just staring in a direction at nothing, but they're not really awake. So that could be a cause for staring. And then sleep apnea itself is not the problem. It's the sleep apnea causing, I think, fatigue can cause daytime inattention. So these kids will stare because they're not getting the rest that they need. So they're really tired during the day. So that's where sleep apnea kind of falls within staring episodes. It's the daytime effects, not anything that's happening at night. But this was only like 5 to 6% of all staring spells in all of the age groups that I discussed earlier. So, a smaller percentage, especially related to inattention. All right. And then migraine. There is a very interesting migraine syndrome. It's called Alice in Wonderland syndrome, but it may cause staring because of the perplexing nature of it. So a lot of times these kids are seeing things that are odd to them. So like a doorknob may seem really, really big, or something may seem really, really small. So these kids are kind of staring at those things, trying to make sense of that because it doesn't make sense. Typically that's related to migraine, typically subsides. It doesn't happen very often, but it can cause staring episodes. And then pain from migraines, right? So if you're having a lot of pain, sometimes you're just staring and you're kind of tuning everybody else out. This can cause staring. And then some auras, which cause aphasias or confusion, may cause them to stare. So if you're kind of confused and you're unable to speak, sometimes it looks like you're staring in a direction when you're trying to make sense of things in your mind, which may look like an epilepsy, but it's not. And then it gets confusing because there are some epilepsies that can mimic migraine. So you just have to be attentive to that it doesn't sound more epileptic and less like migraine. All right. Psychogenic non-epileptic spells. I want to say that this accounted for 11 to 13% of staring episodes in the older population, so 3 and above. And what is this? So typically, psychogenic non-epileptic spells are related to underlying health disorders or mental disorders. So like a lot of PTSD or anxiety, depression, bipolar. So often you're going to see kind of comorbid conditions with this. And a lot of times it'll be episodes of behavior, movement, sensation that do not have abnormal electrical correlate on EEG. So what that means is that if we found this person and they were staring and we couldn't figure out why, and it seemed like maybe it was epileptic in nature, we could do a video EEG to try to capture an event. If we capture an event and it doesn't correlate on the EEG that there's abnormal electrical activity, then we say it might be something like this, a psychogenic non-epileptic spell. Again, typically related to psychological distress. It's not always in the patient's control. So I think a lot of times you hear this, or what they used to be called pseudo seizures, and people think that this is just a fake seizure and they're faking it. But a lot of times they're under such duress that this is kind of the stress way of kind of coming out. So we have these odd symptoms that can come out in staring episodes or full on convulsive episodes. Kind of a strange statistic too, but 75% or more are female typically. And again, this accounted to 11 to 13% of episodes of staring. All right, let's talk about epileptic causes of staring. So generalized epilepsies. So the one that everybody's probably most familiar with are typical absence epilepsies. Normally you're going to see these children and they're going to have an abrupt onset of change in awareness or responsiveness. So all of a sudden you're talking to this child and then they stop, they stare, there might be some behavioral arrest for 5 or 10 seconds, and then they kind of come back to you and just pick up kind of where they left off, like they never left that conversation. Sometimes they have a little reset at the end and they kind of orient themselves and then they come back to. Typically they have little or no change in tone. So these kids aren't falling over. It just looks like they were gone for a second and then came back. They typically don't remember these at all. It's just missing time. They're typically brief in duration. I saw one study that said they can last 30 to 40 seconds. I want to say that most of them are shorter, anywhere from 5 to 20 seconds. And again, post-ictal recovery is almost immediate. So these kids are not having to like reset and restart their computer. They may stare straight ahead. They can have, sometimes they'll have like very subtle eye deviations. So every time they do it, maybe they'll look to the right just a little bit. They might do some associated like lip smacking or look like they're chewing something. They'll do some aimless walking sometimes, which can be hazardous because I don't think they really know where they're going, right? Sometimes it looks like they're fumbling with their clothes, but it's not really purposeful. Or sometimes I ask parents, does it look like they're doing a magic trick that you're not really a part of? And that can give me clues into if this is probably an absent seizure. Typically, absent seizures, they have a good prognosis. If early in childhood, a lot of times we'll see them grow out of this. 60 to 70% of them will. So that's the childhood absence epilepsy. Once they get a little bit older, you get into juvenile absence epilepsies, which the prognosis is not as good for growing out of it, but still fairly good. And then there's juvenile myoclonic epilepsies, which we see a lot in teenagers, but you have to have the myoclonic part of it, so the jerking part of it. And then also under the generalized epileptic category, we have atypical absence epilepsies. So a lot of times these are longer in duration. There's a lot of decreased response. Sometimes there's change in tone. Sometimes they'll fall on the floor. And then a lot of times there's a postictal phase that we won't see in typical absence epilepsy of cognitive impairment, and they're just not acting like themselves. And the prognosis is not as great with this. So you just have to kind of tease out which one is which. In generalized epilepsies, we see changes all across the EEG. So there's nothing focal coming from one part of the brain. So that's what makes it generalized versus not generalized. And then focal epilepsies. So we'll see these with staring episodes too. So sometimes you kind of have to fish these out. Oh, I meant to say on the absence epilepsies, a lot of times we'll see those, 5 to 100 times per day. So you're seeing these every single day. Focal epilepsies, a lot of times I don't see them as often, but that's not always true. Sometimes we're seeing them multiple times per day. But sometimes it's just a few times per week, which is a little bit different than the typical absence epilepsy. But typically focal epilepsies, they're longer in duration. They're almost always 30 seconds. But some kids don't always fit into that box. I have examples that I could give you, but they're at least 30 seconds typically. A lot of times they're 1 to 3 minutes. And then focal epilepsies with impaired awareness. So you can have awareness that is kept with some focal epilepsies, so they kind of know what's going on, and then there's some where they might be able to see, but they're not able to speak back, or vice versa, or they kind of lose awareness totally. They're typically with focal epilepsies, they're more likely to have that postictal state that I think a lot of people look for with seizures. I think that's what makes absence epilepsy a little bit more confusing, because they don't have that state of confusion or grogginess or emotional outburst afterwards or difficulty speaking. A lot of times absence epilepsies, they just kind of continue what they're doing. And then childhood absence epilepsies, these are less likely, I think, but with centrotemporal spikes, you might know that as a benign relandic epilepsy, or what it used to be called. Typically, you're going to see these during sleep, so they look a little bit more suspicious, I think. But there's drooling. A lot of times they're aware, but they can't talk. Sometimes they're making a funny noise, but they can't speak at all. A lot of times there's unilateral facial and motor symptoms. So one side of their face might be drawn up, or they might have jerking of one arm, and then the Pediatric syndrome. They could be aware, then they have some impaired consciousness, which might look like a staring episode. A lot of times if they do stare, it's only briefly, and then their eyes will deviate to one side or the other because these are focal. And then often these are accompanied by like autonomic symptoms and vomiting. And then about a third of these will move on to have a convulsive episode. The paniatopolis are confusing because these are one of the ones that can mimic migraines. So you have to kind of differentiate if this looks like a seizure or migraine, or send them to us so we can evaluate that. All right, differentiating testing. Okay, I'm gonna go back over this, but check the history. If they're able to respond to verbal or tactile stimuli, I think it's much less likely to be a seizure. And I think a lot of parents come in and I'm like, have you ever touched them during an event? And they're like, no, I never thought of that. So I think a good way to educate parents to see if this is a seizure event is to tell the parents to touch them. And if they respond, beautiful, probably not a seizure event. But if they don't respond, then that's going to lead me down a different path and make me more suspicious for seizure. And if they happen more with specific events, like it always happens when they're watching TV, but it doesn't happen any other time, I think I'm less likely to say, hey, this is probably a seizure. A lot of times seizures don't really discriminate, right? They're going to happen whenever they want to happen. That's kind of the nature of them. Now, can they happen with specific things like flashing lights on the TV? Yes, but we can pull that out. And then videos. I think it's very important to see videos if they are able to capture these. A lot of times with typical absence epilepsy, it's going to be a lot harder to capture because of how short the events are. So we're seeing these episodes lasting for 5 seconds, and as soon as you've got your phone out, like the event's over. So that's understandable. So if we're looking at longer episodes, it's always nice to have that video to see what they're doing. Like, do their eyes always go up? Are they doing something funny with their mouth? And that just gives me kind of further information. But again, it's still really hard to tell sometimes. That's why staring episodes, I feel like, are so difficult. And I was hoping that I would find really specific criteria to say, hey, this is what you should send to us and this is what you shouldn't send to us. And if anything, while I was doing my research, it made things more money, and I think sending them to us is probably the better idea. But if they're still unclear, there's high parental concern, I always say send to neurology for evaluation, possible EEG, and we can decide that when they get here. So we can test them. A lot of times, typical absence epilepsies, we're definitely going to see on EEG. I think there's, above a 90% rate that we're going to capture something on that EEG. A lot of times, hyperventilation will cause typical absence seizures to occur, not always. I do that in office sometimes. They do it during the EEG, and we can see those changes on EEG. Sometimes we don't see the outward seizure, but they'll see the seizure or the underlying risk for seizure occur on the EEG during hyperventilation. So EEG will really guide us on the plan. If we're still not sure, then it may require admission for video EEG or maybe to the epilepsy monitoring unit for a few days to see if we can capture an episode, to see if there's correlate, like I was talking about earlier for the psychogenic episodes. Treatment and follow-up. So when we're talking about inattention and daydreaming, a lot of times if we think that it's this and we've ruled out that it's seizure, classroom modification, school support, ADHD testing, and whatever they want to do with that, whether it's, occupational therapy, or they want to try some new things at home, or medications, whatever it is, will help with maybe the inattention portion of it. Typically doesn't require a neurology follow-up. This can normally be followed by PCP or like the developmental clinic. Parasomnias, a lot of times if we do think it's related to this, then I normally say it's a lot of parental support, just reassurance that this is probably a normal thing we're going to grow out of. If we're still not sure, then we can always do a sleep specialist visit. It doesn't typically require ongoing neurological intervention. If we're talking about sleep apneas, may want to get those addressed. I always say play it safe and you guys can see one of the sleep specialists. We have two now. So, and then psychogenic non-epileptic events. It sounds like these would need to be followed by neurology, but typically if we get the anxiety or other underlying mental problem under control, a lot of times this will follow suit. So if we have good support with our PTSD and our anxiety, a lot of times these episodes will not occur as often, or maybe not at all. So normally I say psychology counseling normally doesn't need ongoing neurology follow-up unless there's suspicion for co-occurring epilepsy, which can occur in 10 to 15% of all cases of psychogenic non-epileptic spells. So you just have to watch that carefully to make sure that you don't have both going on at the same time. And I have more than one case where both of these are happening. And I think one of the cases was that they got so stressed finding out that they had an underlying epilepsy that they ended up having psychogenic spells. So that gets very confusing. And then migraine may require ongoing neurology follow-up depending on the severity and frequency of events, right? So if they're happening really frequently, then there might be some things that we can do to help. And then may require neurological interventions or medications. And then self-gratification episodes. This is typically in younger kids. They don't need ongoing neurology follow-up, and counseling and educating the parents is crucial just to let them know that this is normal. And these are the things that we might see. So treatment and follow-up. So for epilepsies, obviously, if we're diagnosed by EEG, this will tell us guide us on the treatment plan and when and what medications to use. Is the EEG always abnormal? No, because nothing fits in the box in neurology. So sometimes we're just treating the clinical picture. Some epileptic disorders, so like the epilepsies with centrotemporal spikes, and the Paniotopoulos sometimes don't require any pharmacological intervention. And then sometimes EEG characteristics or characteristics of the seizure, if they're focal, will expose the need for imaging like MRI just to make sure that there's not a focal lesion somewhere causing these problems to happen. Most epilepsies require ongoing follow-up with neurology. And then rate of the follow-up is determined by the control of the seizures, right? If seizures are happening very often, then we're going to want to see you back more often. Could grow out of the tendency, so that's good. All right, and that is it. Any questions for me? Right. Well, that is all I have. Thank you guys for listening.